environmental? Are there more we can do in terms of housing design? For everybody, which means people don't need to have special equipment or services if we can design things better to start with. And then in terms of children, to avoid children becoming looked after, there's definitely something for me about a much better arrangement where schools, mental health practitioners, leisure services, education and social care come together to really start to understand how can we better support those families so that children don't become neglected and then don't come into the care system. So early intervention and support is absolutely critical, but we need to get better across Wales in sharing what works, why is it working, and then rolling that out across the rest of Wales.
Thank you, Sue. Eve, have you got a response to the idea about early support?
No, I would just completely agree with what Sue said. I think early intervention is key. I also think, going back to one of the comments Sue made earlier about, health has become more about illness, and we really need to sort of focus on the person. So, keeping people healthy and well at home. We know that social isolation and loneliness are one of the key problems that we have in Wales. So I think early intervention from all perspectives is absolutely key.
Fantastic. Thank you, Eve, and thank you, Sue. I've got questions from Cyril and Claire. I'm going to start with Claire, if that's okay.
Hi, can you hear me?
Yes, fantastic.
Thank you. Diolch yn fawr iawn. I have a question for Evelyn Parkinson. Thank you for your talk. Absolutely, what you said about, in a way, rethinking the NHS and healthcare regarding the elderly, and your comments about how they are known to deteriorate significantly when they go into hospital and can be much better off at home if the care can be provided. The problem seems to be that you come up against all kind of arguments why not to do that, such as you need 2 nurses to sign off with medication and everything. So my question is, there are certain models, aren't there, where the healthcare trains family members actually who want to be trained and who want to participate. They're already the nurses and primary care at home, so they want to participate in giving the medication. There are models in Outback Australia, for example, where family members are trained to give medication, and there surely should be more trust and investment in the family members in providing the care if they are doing so. That's my question.
Fantastic. Thank you, Claire. Sue or Eve? Go on, Eve.
Yeah. I would completely agree, Claire, and I think that the person and their family should be
Are there
integral
more
to
we
all
can
elements
do in
of their
terms
care,
of
whether it's from a
housing
health
design,
perspective or from a social
for
care
everybody,
perspective?
which means
I don't know if people have heard of a campaign that's been used in hospitals called the John's campaign, whereby people who are family or carers for somebody who has dementia are able to be part of their care and support on the ward. So, at the end of the day, whether someone's in hospital or in the community, that place is where they are at the moment, but their family is always their family. It's just a little blip. But just from what you were saying early on, Claire, so I also think we need to be thinking quite significantly about, people stay in hospitals, but that the medical profession, there is a propensity to over-medicalise. And the focus should be on what's important to the person, what's their quality of life, not about testing, diagnosis, because these are the people that, it's an unfortunate term they use at the moment, but who end up stranded in hospital. And then it's social care that then has to try and pick up the pieces, providing more and more care when it wasn't always necessary.
Great. Thank you, Eve. I'm just aware of the time, so I think we could talk about this all day, but we've got half an hour, so I'm sorry about that. Thank you, Eve. I'm going to go over to Cyril and then Tafsila. So Cyril, first of all, nice short question, Cyril.
Question for you, Evelyn. Do you get trouble when somebody is going to be discharged from hospital and you've got to wait because there's no social worker around? This happened to me last year. I broke my wrist, right? Sober. And I went into hospital. Okay, I'm ready to go home now, right? No, we'll have to wait for the social worker for 2 days before you can leave. And 2 days along, you come home. Okay, off you go. Do you get that problem?
Right, thanks, Cyril.
Every day, Cyril, all the time. I think that there's a level of risk in the hospitals as well, where, you know, people are told things like, you can't go home unless you have care, you can't go home unless this happens. And I think that worries families. It sometimes makes people think that things are worse than they really are. So sometimes I have the scars to prove of how challenging it can be to get somebody out of hospital sometimes, and how challenging it can be to stop people going into hospital. We've actually had staff, you know, literally locking doors and not allowing them to be taken into hospital because they know that that's not what that person wants.
Yeah.
Fantastic. Thank you very much, Cyril and Eve there. I'm going to take a question from Tafsila now. I'll read it out for you. It's directed at both Eve and Sue. And Tafsila wants to know about direct payments. She wants to know, why do you think the uptake hasn't been as high in Wales as compared to the rest of the UK?
Should I go first?
And I was going to say, Sue, go first.
Okay. A couple of years ago now, we did a bit of a survey from a Social Care Wales perspective, because I kept being asked that, so I wanted to find out, so why? And it's like all questions that you ask, the answers give you more questions. But certainly some of the elements that came out was, first of all, there was a myth that direct payments weren't being used. So we unpicked that, and actually right across Wales, they are being used, and the numbers are growing, but growing at a pace that's slower than we would want. The main elements that seemed to come out was there was a lack of willingness, particularly for older people, to take on that role of the employer. So with the direct payments, as many of you will know, if you need that care and support, you need to employ the person to act as your personal assistant. And for many people, and particularly older people, the evidence suggests that they didn't want to do that. Now, most parts of Wales do employ third sector organisations to provide that hands-on support. So you can, if you like, purchase from a third party to get the support worker you want. But again, I think it's another area where potentially across Wales we could do a bit more collectively to perhaps keep promoting, and maybe using people who are actually using direct payments themselves to act as that stronger voice. And again, it's something you could think about. If you think it's something we need to push across Wales, think about including it in your recommendations. Thank you. Eve may have some other examples.
Thank you, Sue. Eve?
I don't have a great deal to add to what Sue has said. I think that pretty much is the picture. I think the only thing will be that we do sometimes have people who want to go down the direct payment route, but again struggle to find PAs or recruit PAs doing the role.
Thank you, Eve. I think that sentiment is echoed by Bethany, who also says she was on direct payments but found it hard to get the staff in Wales to support her, so she had to go on to home care. So thank you for that. I'm going to now go to Nina's question. And the reason we're doing this is because of intermittent Wi-Fi for everybody. So that people are texting us like crazy. So please continue to do that. So Nina has felt that COVID has highlighted how there is little consistency for social services support across Wales. And people have been left with no support. Why do you think that is?
Eve, do you want to go first?
Yeah, I mean, I can only speak for Monmouthshire. And as far as I'm aware, and I hope that this is very true, that people haven't been left with no support. We've had a very changing picture. In the early days of the pandemic, we had quite a lot of people who stopped calls. That was for a variety of reasons. You know, family came to stay, or they were concerned, or husband and wife, tried to support each other. We actively phoned lots and lots of people. Visits to people did slow down or go down to only the very essential visits, but we were still doing a lot of things by telephone or virtually, or through lounge windows or in back gardens on a good day. So as far as I'm aware, in Monmouthshire, but I can't speak for every other borough, then we have supported everybody that's needed support.
Can I just add then an example I'm aware of in other parts of Wales? One of the things that happened was certainly day activity centres were closed on a temporary basis because of the risks of COVID. But those practitioners and professionals who would normally work in those settings were brought in to help with helping the most vulnerable, who were shielding with food supplies and other real practical things to enable them to still avoid loneliness, isolation. And as Eve mentioned earlier, that's a bigger killer as somebody smoking and at risk of cancer. And I think sometimes we underestimate the impact of that lack of social interaction, that social care it's fundamental to our business. Thank you.
Diolch, Sue, thank you very much. I've had a question here from Victoria, and it's about training of staff and staff opportunities for training. Just to sort of consider I suppose there's two questions here. Is consider what's essential training, where Victoria feels things like autism, invisible disabilities, person-centered planning are all what she would consider essential training for staff within social care. And so it's about those, I guess it's about those training opportunities, and what would you say would be essential for the staff to be trained in? And I'm going to go to Sue again.
Okay, thank you. Well, obviously, that's a fundamental part of the role of Social Care Wales. We've spent the last 3 years unpicking and completely redesigning the qualification requirements for our frontline workers. So we now have a suite of NVQ equivalents from level 2 up to level 5. That, previously there were hundreds of different sorts of qualifications and training you could do, and we've really standardized that now. So anyone new joining the service, particularly anybody who has to be registered with Social Care Wales, will go through the same training to make sure everybody has those basic competencies. And it would include things like invisible disability and some of the fundamental tenets of Social Services and Wellbeing Act. But obviously, whoever is your employer would also need to continuously ensure you were getting the latest advice, guidance, training and resources to help you stay ahead of the game in terms of what is the latest thinking. But the basics are all there through our regulatory framework. That's the beauty of having a regulated workforce. And then your additional individual needs for individual people that you may be supporting. We would expect employers, whoever's employing those individual workers, to take the responsibility to making sure specific needs of people and the training requirements are met. Thank you.
Thank you, Sue. Eve.
Yeah, following on from that, I think one of the key points that I picked up from the question is that element about having person-centered plans and person-centered care, and I think that that's what our focus needs to be, because you can do a lot of training around specific conditions, disabilities, illnesses, whatever you want to call them, but fundamentally what the Act is saying is it's about doing what's important to that person as a human being and enabling them to have good days. I'm going from this meeting to another meeting where we're talking about how we deliver collaborative communication training to all our domiciliary care staff, all the independent sector and all the third sector. Now, obviously that won't happen overnight, but the focus of that is about people being able to have asset-based conversations with people, so that we can start to deliver or continue to build on the delivery of really person-centered care. Thanks.
Can I just add to Eve's comment there, because again, another programme that Social Care Wales does right across Wales, and we've already supported thousands of workers with that outcome focused planning programme, which again is a programme of activity which helps people really start to think about what is my role. It's more of those fundamental values and principles about helping people think about what matters to them. So running alongside those qualifications is this programme that Eva said, Social Care Wales provide that right across Wales.
Thank you very much. There was an additional query around that as to how is the training monitored and evaluated. Is there anything you'd like to say about that?
I mean, I can talk from a regulatory point of view. Because of those redesign of the qualifications I've just described to you, there are several organisations already regulating and monitoring those new qualifications. So City and Guilds and WJEC, they are monitoring how they're being delivered in those FE colleges and workplace learning. And then our relatively new organisation in Wales called Qualification Wales, they also monitor from a, does it meet the standards? Is it being delivered? As a workforce regulator, we do have the authority to also regulate all of those training in terms of the delivery end. In terms of what difference it's making to individual practitioners, we would pick that up when they come to revalidate or re-register with us. We would check, have they been continuing the learning? Are they applying that learning? So to ensure that they're staying up to date, they're continuously learning, our regulatory arrangements make sure that they tell us what they've been doing, how are they applying it in their roles. But obviously from an employer point of view, they would want to make sure that that training and qualification development is making a difference to the front line. And, you know, Eve may want to say something about how that happens in Monmouthshire.
Yes, thanks, Sue. Yeah, I mean, basically, it almost becomes the bedrock of everything you do. So, you know, we don't have multidisciplinary meetings. We have what we call community conversations. And the conversation about when we're talking about people will be, you know, what was that person's outcome? And what did they want to achieve? What matters? Are we doing that? If not, why not? What do we need to do? It's covered in one-to-ones, paperwork. What we measure is outcomes. Did people achieve the outcomes? The paperwork that the domiciliary care staff do is based on a personal plan around what matters to somebody, what do they want to do every day, what do they, you know, so it's just trying to constantly embed it into everyday practice. And then, you know, I can look up somebody's records, a member of staff, and look at the people on their caseload, and I do this, and we use this as a training sort of agenda, and say, you know, is this person having the right conversations? Are they setting good outcomes with people? If not, why not? What do we need to do to take that forward? Thanks.
Thank you very much, both of you there. We've got an additional question from Nina about, I guess, how the social care services and the third sector work together, and the danger of gaps appearing, I suspect, you know, and the role of regulation in that also, so that we get this consistent level of service. So how do you account for that? So you've got lots of different players in this scenario. How do you ensure that they're all consistent and that no gaps are left and people fall through the gaps?
Should I kick off?
Yes.
Oh, okay. So from a national perspective and from a regulatory perspective, we worry less about who's the employer. We are concerned with the quality of the practitioner. So all of our learning and development resources, which, you know, they're not just about qualifications, that's part of it, but it is about those programs of support, what works, person-centered planning, outcome focused programs. We have a range of programs that we support the workforce with, and they are available to anybody working in social care, whether you're paid by the third sector or whether you're employed by a statutory or a private sector partner. So that's where we're trying to have that consistency. And if you think about it in the way that we're different to the health service, in the health service, we've got 7 health boards and 3 NHS trusts. It's much easier to issue a missive from government, isn't it, and say, thou shalt do this and do it in this way. When we're working with the third sector, independent and voluntary sector, plus statutory bodies, we have to think a bit more creatively about creating the right conditions for those employers to want to work in that way, in line with the principles of Social Services and Wellbeing Act, and the frontline practitioners are enabled and supported to work in that way as well. I mean, there are over 1,000 different adult social care providers providing social care in Wales, so you can't use that command and control approach in the same way. Plus, what I mentioned earlier when I was doing my presentation, if we try to nationalise everything, we move away from meeting individual people's needs. And one of the brilliant things about the Social Services and Wellbeing Act is it gives those frontline practitioners that ability to have those conversations about what really matters, what's important. So we have to balance national standards but meeting individual needs and reflecting the local population. So that would be my response. Eve may want to add more. Thank you.
Thank you.
Yeah, I think one of the main things is around communication and collaboration, and I don't say that sort of glibly. I mean that we really have to get down and understand this properly. We have to work towards you know, our services and the third sector and the independent sector becoming almost a virtual team. You know, we're hopefully going to be testing something out in Monmouthshire soon, which is we're calling it place-based care, where we're looking at Monmouthshire as 12 little place-based teams, and in those teams will be everybody that works and supports people in that defined area. So whether that's housing, third sector, community centres, our services, health services, so they then start fully to work as a team. And I'm hoping that will make sure that there aren't those gaps, there isn't any duplication, there isn't any divide, and that we all are working to the same purpose for the people of that community.
And just to add to what Eve said, in other parts of Wales, they're using a similar concept, but they're calling them neighbourhood care networks or GP cluster frameworks. So I think if you look across Wales, they may be called something different, but I think everyone is working towards the model that Eve has shared with you from Monmouthshire.
Okay, thank you very much, both of you there. Thumbs up from Nina, thank you. I've got Giles and Rob, Tristan, and then I'll come back to Claire if we've got time. Is that okay? So Giles Palmer has, do either of you think that there's a tension between the training of social care staff and the need to provide person-centered support, or over-professionalising the person-centered kind of support? And look at you, Evelyn, to start that one.
Have I been naughty? Gosh.
Oh, no, you haven't. Not yet. Sorry. Oops.
That's okay. I think it's becoming less so. I think that, you know, training, there was a tendency for it to become over professionalized. I think there's much more, you know, it's very, people get very wary about the sort of generalist and professionalist sort of conversations. And I think that everybody's a generalist, and then you're a professionalist within that. So, you know, we want to get services which are more seamless, more person-centered, and people are expanding the scope of what they do, so that we need to move away from those very professional silos. That's not undermining a professional social worker, occupational therapist, or a nurse, but it's about them expanding their practice so that they can, you know, work on the sort of softer edges. But it is all about the person. That, you know, the person and their family and the community that they live in is the direction of travel. And I think that we are seeing a move towards that, but it takes time. So do you want to add to that?
Yeah, thank you. And it's a really good question, I think, because one of the first things we did when we started thinking about regulating and registering the domiciliary care workforce, we had that real concern about losing the real essence of this is a caring role. And we don't want it to be too much focused on you have to reach this very high standard of a qualification. A, it would put people off, but B, we didn't want to lose that focus. So what we did to compensate that was the very opening part of your qualification journey starts off with what we describe as a values and principles award. So everybody has to get that first. And that's almost the place where you test out, is this individual going to be suitable to work in social care? They may not have the right values and principles. So everybody does that first. And for, when we first opened the register again, we gave people, if they'd been working in the care sector for a number of years, but they didn't have any qualifications and they were terrified of the idea, we've said to them, get the values and principles award right, work with us, and then by the time you come to re-register in 3 years' time, that will give you those 3 years to get the qualification that you need. So I think it's that balance between the ethos of what we're trying to achieve in social care, the ethos of person-centered planning, outcome focused as part of the Act, but we do want to have some expectations and standards for our workforce as well. But, we don't want to lose the individual out of this. So I think the Values and Principles Award was a great way of bringing all that together. Thank you.
Thank you very much. Fantastic. We have a question from Rod Tristan asking about your views on community resource teams in health and social care. Are you supportive of them, and if so, why? And Eve, I'm going to start with Eve there.
Well, no. Yes and no. I understand the principles of the community resource teams, and I think that the fact that you've got health and social care colleagues working together is very positive. What my thoughts are, and the route that we've gone down in Monmouthshire, is we don't have community resource teams. We have completely integrated teams. So our view is that journey should be seamless. So if you're a social worker who has been seeing Mrs. Jones, for example, then you should be seeing Mrs. Jones wherever she is on her journey, whether she's in hospital, in the community, having rehabilitation, whatever. The same, and that goes across the piece. However, I do understand that other areas are at different parts of that journey. So I think that community resource teams, I understand, what they were set up for, but I think that what we should all be aiming for is full integration of the teams in the community. So we don't have people being moved from one bit of the business to another bit of the business, or having multiple people going into their houses. It should all be based on a relationship. And, if you're involved with that person, then you stay involved.
Great, thank you. Anything to add, Sue?
I would just reflect in terms of what we did in Torvine in children's services, because it's a similar thing, isn't it? Whatever design you have for your teams, there's a potential for silo working, and you may cut it up slightly differently. So in children's services in Torvine at one point, we had separate assessment teams, separate referral teams, and then separate care management teams, a separate child protection team, and so we go on. When I joined Torvine, I started looking at that and thinking, well, this doesn't seem to make sense. There's these handoffs all the time. So we moved into what Eve described earlier as this place-based approach, and we called it patch-based, but it's the same sort of thing. So you had a range of professionals supporting the needs of children who are vulnerable and their families based on a geographical area. And I certainly found that to work very well. We didn't call them community resource teams, but I know in adult services, some of them are called that. And I think no matter what your system is or what your team is, it's the individuals working within it. I think it's about everyone focusing on the citizen, the person, having your professional badge, which is important to you, But when you're delivering your work, you have to focus on the person and the community you're serving. And if we can get that right across health and social care and other public services, we will have an even better, enhanced service for our customers.
Thank you, Sue. I'm just going to skip to Jo Parsons, who's asked her first question. And if we've got time, we'll go to Claire. But it's a very quick one from Jo, but might not be a quick answer. It's how should organisations approach positive risk? Eve, would you like to start with that one?
I'll be very quick in my answer. They should approach risk positively. They should approach positive risk positively. The risks are those of the individual to take, and they have choice. It's up to us to enable them to make the most of those choices and to make them aware of what they need to think about in making those choices. It's not our job to stop people doing it.
I would simply echo Eve's comments. Absolutely, it is about respecting that individual's decisions and helping them understand the implications, but not terrifying people and saying you can't do that because everybody has the right to take risks, don't they, in all parts of life.
Yeah. Thank you, Sue. Thank you, Eve. Claire, I think this might be the last question.
Thank you. Can you hear me?
Yes.
Thank you. Just about the cluster groups, you talked about the GP cluster groups and the pilot in Monmouth, where you're hoping to have these seamless integrated groups. Can I just ask, you talked about social workers, OTs, nurses, housing people, but can I ask in real terms, where is the family member who's actually the daily expert, the daily carer? Where are they situated in that cluster group? Because it's all well and good having an aspiration to include them in everything, but how does it work structurally, if you don't mind me asking?
Oh, no, not at all. I don't mind you asking at all, Claire. I'm not sure I have all the answers yet. What we're doing is when we talk about when Sue talked about the neighbourhood network clusters, etc., that we've got 2 NCNs in Monmouthshire, and what we're trying to do is break that down even further into 12 places. So that means we take our services almost as near to ground zero as we possibly can. And by doing that, then hopefully that will ensure that the citizen and their family and the community that they're living with become an integral part of it. But we're just on the journey now. We're talking to community centres, we're talking to people into what that would look like and how that happens. So I don't have the answer, Claire, but we're working on it. We're trying to get there.
Thank you, Eve. Sue, anything to add?
I would just add, again, for the jury members to make the use of their citizen panels in each of the RPB areas. And that's where you really need to try and raise the voice of family members, carers, as well as individuals who may require care and support. Really use that mechanism. If you think there are issues in your area, feed those in to your citizens panels. So raise the profile there. Thank you.
Thank you very much. Diolch yn fawr iawn I chi gyd. Thank you very much to you all. We've reached 3 o'clock, and this is the end of this. Now you have finished, Eve. So you have finished. Thank you very much for taking part, both Eve and Sue. We really appreciate your involvement and honesty, and being such enthusiastic witnesses for today's jury. So we're going to stop the recording now.